My name is Brian Myers, and I'm a thoracic surgeon and a professor of surgery at Washington University School of Medicine and Washington University Physicians of Illinois. The greatest benefit to screening is that the fraction of patients with cancer who get cured goes up and up and up as more and more cancers are detected by screening rather than by symptoms. In the early trials that paved the way to wide adoption of screening, in many instances, the rate of positive screens was as high as 30%. However, it was only about 1% of the overall group, 1 out of 30 from the positive screens that actually turned out to have cancers. There's really a lot of evaluation and sorting out that has to take place in order to adequately treat that 1% without having the much larger number of people with positive screens be burdened by excessive testing or certainly excessive surgery. Typically, somebody needs to have a high enough risk of lung cancer to make the screening worthwhile for that individual. For the people who are considering lung cancer screening, generally the qualifications for that screening process depend on age and smoking history. The majority of nodules or abnormalities that are found on a screening CT scan turn out not to be cancer, and that's why a lot of discussion and judgment is required before taking any action on a screening result. After the CT scan has been performed and the radiologists have identified something that looks unusual, that will usually trigger a visit between the patient and another practitioner. It might be a pulmonologist who specializes in diseases of the lung, or it might be a thoracic surgeon like myself who is very knowledgeable in lung cancer and lung tumors. The patient will sit down with that practitioner, review the findings from the radiologist, review the nodules or the images themselves, and then craft a plan that might suit the individual patient and the individual findings on that CT scan. When somebody has a positive screen and they have a lung nodule, we can really boil down the path forward to 4 options. One option would be to do an operation to remove the nodule. Another option would be to have a radiology or a bronchoscopy guided needle biopsy to sample some cells from that nodule. A third option would be to get a PET scan. And a fourth option, which is probably the most commonly chosen option, is to do nothing but have close follow-up with some additional imaging in the very near future to see, what's going to happen to that nodule. And so if we have chosen the option of observation, then usually what's discussed is what's the interval of observation. Everyone's nervous, and so we'll start off with a shorter interval, say 3 months, and usually it's a CAT scan without contrast. So it's, again, no needles, no sharp objects. And then based on the interval change of the nodule, we have a much clearer plan. For instance, a small suspicious nodule that gets a little bit bigger in that short period of time, that's identifying itself as a threat. Whereas, in many instances, the nodule will get smaller, which is immediate relief to everybody because cancer doesn't get smaller. If a nodule is unchanged, then it could signal that it's a scar, or it could signal that it's a very, very slow-growing process, and that would probably lead to additional observation. I think one of the keys to guiding patients and their families to a sound decision is to make sure that they have a full understanding of all the options that are available. And for me, that involves a lot of pictures and drawings, to show the patient what has been found and highlight some of the significant aspects of that, but also to jot down as we're talking the lists of opportunities and options that the patient gets to choose from. Hearing it is one benefit, but then having it written down, I think, is also extremely valuable, particularly after the visit is finished and the patient is mulling their options at home with their family. Lung cancer, like any other cancer, is always easier to cure the earlier it's found.